Well, good morning, everyone, to OUH talk this morning in English, because we have a very special international guest this morning from Canada, professor in strategy and entrepreneurship, and Snowdon. We're looking very forward to hearing your lecture. It's about supply chain maturity and supply chain maturity. What are we talking about? Well, there's a lot of text on this slide, but it's really about how your supply chain's infrastructure can have impact on the patient safety, on quality of care, and about costs. And it's also about what kind of strategies you should consider to strengthen your supply chain's infrastructure. So very exciting stuff this morning, and very welcome to you. And I'll give you the word now. And remember, as always, you can ask questions on Twitter. So welcome.
Thank you so much. It is indeed an honor and pleasure. It is my first trip to Denmark, and I shared with my colleagues last night, I may not go home. It is such a beautiful country. And you have created phenomenal weather as well, as we all head into very cold winters. So thank you. It may seem a little strange to be talking about supply chain and maturity and patient safety. I started my career as a pediatric critical care nurse, so I feel very much at home in a hospital setting. And what I really went after, the supply chain concept, has everything to do with patient safety. So I hope this morning I'll walk through some of that thinking and what I see as opportunities. And I'm very much anxious to learn from you here in Denmark as to some of the many advances and assets I think you've made compared to many of our North American health systems. So why do you even think about supply chain maturity? This is a simple global map that identifies a problem that every health system in the world is facing now and is facing likely into the future, and that is the cost of delivering healthcare services to the populations we serve is far outpacing our country's ability to generate the GDP and the wealth to support our health systems. If you have a look at the map here, of course, North America is clearly in last place. We are spending upwards of 17% of our GDP to deliver healthcare. And of course, the growth of GDP is growing at far, far lower numbers, 5% in 2017, and likely lower than that. So we are on very much, as a business school would describe, the edge of the cliff, but in my world, never waste a great crisis in order to pay for health services, but to transform systems to deliver value and safety for patients. And when you look at what we're spending, that's one thing, but if you're going to spend a lot of money, hopefully you're actually going to achieve much greater performance. That is simply not the case for the North American health systems. We spend more per capita than any other system globally, and yet we are ranked number 9th out of 11 OECD countries for Canada and 11 out of 11 countries in the US. Canadians have this tendency to look to our colleagues in the US to learn about terrific health system innovation. I've never quite understood that, given that their performance is quite low in terms of quality, safety, efficiency, productivity, all those great things. And their technologies are wonderful, but they are spending far more money than is sustainable for any really length of time. The real reason that drove much of this research for me is the concept of medical error. In North America, medical error is now our third leading cause of death. As a nurse, that is simply difficult and unacceptable. I showed a bit of data. 23,000 Canadians annually do not survive a hospitalization due to error, most often preventable error. In the US, of course, they're a much larger population. It is 250,000. That's similar to actually wiping out an entire community, small community in that country. And Neil shared with me last night the numbers in Denmark are approximately 5,000. So the question is, how is it possible with our technology, our expanding knowledge, evidence-based care, quality safety initiatives for decades, how is it possible that those numbers are as high as they are? And are we able to figure out how to prevent them? We spend a lot of money, time, energy, resources on patient safety, but we haven't moved the needle on those numbers. So what I'm suggesting today is perhaps we need to think differently about patient safety and look at the environments our clinical teams are working in, create and shape those environments, which makes it much harder for errors and adverse events to occur, leveraging technologies and data flowing from what products we're using, in which care processes we're delivering for individual patients, and what outcomes we are achieving. So let me walk you through some of those ideas. The other drivers in our health systems is the whole concept, and we hear a lot about this, personalization. Now, depending on who I'm speaking to, personalization means genomic level personalization. For others, it means how do we zero in and deliver exactly the type of care every individual patient needs, when and where they need it to achieve the best health outcomes, quality of life, and so on. There are two drivers of change, which is actually going to likely influence how our health systems transform or not. One of them is the personalization and some of the research coming out of the genomics or the omic sciences. There was a recent study presented out of one of our teams in Toronto around the genetic ability to metabolize drugs. So people who are prescribed depression, they've now mapped genomic heritage, if I could use that term, and depending on where your genetic basis comes from, whether you're from Oceania, Southeast Asia, Canada, Africa, Europe, you have varying degrees of ability to metabolize those depression drugs. And they've actually identified sectors of our populations. Some are super metabolizers, so it doesn't matter what drug dose that you're using, they metabolize it so fast their blood levels never get high enough to be effective. And then there's those that can't metabolize as nearly as well as the average population. So those blood levels get very high, very toxic very quickly, and actually cause harm. Here's the challenge. When a patient walks through that door and is in a clinic for depression, anxiety, any of these mental health challenges, how do we know if they're a super metabolizer, they're not able to metabolize those drugs? And in fact, we have a great deal of difficulty identifying which of these therapies are working best for whom and under what conditions. The second issue is information technologies, and that's shifting our consumer culture in health systems. When I started as a nurse, we were very much socialized as clinicians to be the expert and ensure patients had all the knowledge and best evidence they needed to follow the prescribed clinical pathway or best evidence or best practice. Consumers are now deciding whether you will actually negotiate and become a partner with a provider, teams completely shifting that relationship. It's very much a generational shift we're seeing in North America. I'm not sure if it's exactly the same in Europe, but in our parents and our baby boomer population, they have a very different set of core values than our millennials coming up behind them. And I see it often in my children. In the older populations, we value stable relationships. We will always go to the providers we know or we know their family, and we value that relationship among all others. We see healthcare as a service. We're very loyal to our healthcare team or to the community where we seek care, and we usually defer to the expertise of the provider. The millennials coming up behind us, not a chance. They value, they're impatient, they're super connected, they're very loyal to value. They don't assume because they know you as a provider or they know of you or that team that that is the right provider. They spend a lot of time online, they research, and they are the ones that are going into clinician offices and clinics with their list of questions from Dr. Google, which is what we affectionately refer to, and they are actually negotiating. So we have quite a consumer demand shift in health systems that we haven't seen in prior generations, which is starting to drive not only change in how we deliver care, but expectations among our patient population. Here's the other dimension that I think speaks to how health systems need to be thinking about infrastructure to track and trace what products, what outcomes are we achieving. This is a study out of the journal Nature by Nicholas Schork, who looked at the top 10 drugs prescribed to the American population. Some of these, I'm not sure if the names are the same in the US, but Advair is for asthma, Crestor, very popular for cholesterol, and Humira for rheumatoid arthritis. The blue people on that graphic are the numbers of patients who actually achieved value from those medications and therapies. The red people are the group that, the quite large group, either achieved no value or may have experienced harm. So the challenge is, as new therapies are coming on the market, genomic therapies, biologics, many with great deal of complexity, how is it possible health systems are going to know which of these populations we serve are the red people or the blue people, unless we can track and trace which individual patient is receiving what products, what types of care, service delivery, and achieving what outcomes. And that's basically the premise and the need for a very integrated supply chain into our clinical systems. Now, often people tell me, particularly physicians, and I'm married to a physician, so I totally get that culture, said, you got to find a better name. Supply chain has no meaning for the average clinician. So forgive me. If Denmark comes up with a better name, I would more than happily adopt it and give Denmark all that credit. So supply chain in my world is the tracking and traceability of every product, every care process delivered to every individual patient by the individual or team of clinicians, uploaded and linked to outcomes. So we're no longer just delivering care based on what clinical trials suggest or best practice pathways, but we're delivering care in a way that tracks and traces every outcome so we know which population segments are these blue people that are achieving the best outcome and which are not. And that allows you in your procurement teams to start to procure the products just for those population segments that are going to achieve value by receiving them. So clinical trial evidence is no longer enough, in my mind, with the complexity and the rapid uptake of new therapies, new processes of care. They are certainly the entry-level evidence that suggests there could be value, but until we start collecting what I would suggest are real-world evidence, what's working best for whom and under what conditions, we're not going to achieve the level of quality and safety that many of our populations actually expect. So really, I'm reframing the whole challenge of patient safety in terms of the clinical environment and the infrastructure we work in as clinicians to help us make sure that when we're delivering care and using particular products, there are double checks and alert systems in that environment that proactively tell me if this is the right medication for the right patient at the right time, dose, and delivery before I give that medication, not afterwards. And when you think about it, every other sector has already created that environment. When I go to the Copenhagen airport on Friday, they will barcode my passport and my boarding pass multiple times. They know when I got to the airport, when I went through security, when I got to the gate, what plane I got in, what seat I sat in. I haven't found a health system globally that can do the same. When did that patient arrive? Where did they go in that clinic? How long were they where? How long did they wait? Who did they see? What care did they receive? And did it achieve value or not? And that's essentially what I mean by reframing the issue of patient safety and quality, leveraging the clinical environment infrastructure we have and creating those supply chain, for lack of a better word, or label tools to help us achieve value. So, does this actually happen in health systems? Well, there are 3 global health systems that I was able to find, and I did a very deep empirical qualitative case study on each of the 3. What I was looking for was to define the evidence of value. Does this all just sound like a theoretically possible or good idea, or does it actually happen, and does it actually achieve value for patients, families, first and foremost, and second, is it feasible for clinicians? I grew up in the what we affectionately called the pre-internet phase, and then all of the EMR technology came at us as nurses, and that had varying degrees of successful implementation. So is there actually evidence of value and impact? Because if there isn't, then we need to create it. And if there is evidence of value and impact, how do we disseminate that value and so that all health systems have access to it? So I studied 3 systems. Alberta Health Services in Canada, that's in our western province of our very, very large country. It is a landmass larger than the state of Texas, and it has 4.2 million people who live there, everywhere from the very dark, very southern point of the American border right up to the near Arctic Circle, with many, many rural and remote communities. UK, National Health Service in England, has started down this road. I'll share the findings of that. Mercy Health System in the US, headquartered in St. Louis, that spans 45 hospitals covering 7 US states. So exactly in a very high-level snapshot, what did these health systems do? Well, the short answer is every one of them embarked on a different strategy. And yet they all achieved very similar outcomes, which is interesting. It would suggest that a supply chain infrastructure strategy needs to build on the strengths and infrastructure and context specific to that health system. Denmark, small geographic country, highly digitized in terms of its health system from what I'm learning and understanding, and I have much more to learn, I'm sure. But building on the current strengths of the infrastructure is what's critical when you're implementing the supply chain strategy, not throwing out absolutely all the assets and infrastructure, but starting where you're starting. So Alberta, what they did was collapsed their entire healthcare system into a single regional health authority. It was a political decision because the politicians decided they were spending too much money. Simple as that. Caused a fair amount of chaos, as you can well imagine. But they have now never waste a crisis for Albertans. What they implemented was a province-wide infrastructure, ERP system, online adverse event reporting system. So in about 20 minutes, if you ask them, show me where every IV pump is in the province, they will identify it exactly, tell you when the software was upgraded, tell you when it's due to be refreshed and renewed, and give you a list if that piece of equipment has had any equipment failures, as well as patient events similarly. They have just about now starting to implement an Epic EMR system. By the time that system is in place, it's one of the larger installs of Epic. They will be able to link that scanning, tracking, traceability of every product, every equipment, right to a patient outcome, but they haven't started that quite yet. In NHS, Scan for Safety is the program that the Department of Health implemented. They invited NHS trusts to participate in the program. If you're selected, they were funded for £2 million British pounds to implement the supply chain infrastructure in those trusts. They selected 6 sites who have just completed that 2-year implementation of this tracking and traceability infrastructure. Interestingly, the Department of Health invited them to participate, selected the 6, but each of those 6 trusts had to deliver very specific phases and milestones in order to access the funds. So they spent a very intense 2 years with heavy oversight by the Department of Health to make sure they hit every phase, including every patient had a barcode on the ID band. Every room in every building of the NHS Trust had to have a barcode. So if you went through that door to an exit, you could scan that door and know exactly where that person was in the event of a fire or an event or a patient was lost. The Mercy Health System, completely different, of course, context. In the US, it's about revenue. I often refer to that in my lectures as follow the money. So in Mercy, they were finding dropping revenues for their system because of changes in reimbursement with Medicare, Medicaid, and the VA, Veterans Affairs, and bundled payment models. So although their patient volumes were going up, their revenues were dropping. It's not survivable for a health system in the US. So they had to find savings in their system. They opted for a supply chain infrastructure strategy to reduce waste. And they made very specific decisions on where is the waste in the system, how do we remove it to reduce our costs and therefore restore our revenues. Here are some of the findings across the 3 systems. By implementing the tracking traceability digitally with simple barcode scanning and in some high specialty areas, RFID tags, they created and identified that transparency very quickly became evident of what patients are receiving what care by what providers and where is the clinical variation. So one of the chief of surgeries for head and neck told the story of as soon as I walk out of the operating room, I take that slip of paper or that digital record of exactly what I have spent on that case. And then in departmental meetings every month, they all compare each other and say, well, Dr. Snowdon spent $1,800 on that case. Dr. Larson spent only $1,200. Dr. Snowdon, why are you spending so much money? And what's the clinical variation? And by the way, did it matter to that patient? Did they have better outcomes? So they very quickly allowed and enabled surgeons to decide where and how to standardize practices to get to the best outcomes, but also standardize products they use in those cases. So they're spending the least on the products, getting the best practices and outcomes patients need. The other return on investment, no matter who I speak to in global health systems, they all say the same thing first 30 seconds of the conversation. It all sounds wonderful, Anne, but how much does it cost? It sounds expensive. In fact, it's one of the very few innovations I've seen in health systems in the last 10 years that generates enough savings in the system, perhaps to self-fund it. So when we look at Alberta, now recall that they have not yet gotten to the point of care scanning at the patient level because they don't have the EMR system in place yet. But in the last 7 years, they have saved $301 million simply on standardizing and managing waste on their inventory alone. It does not count for the drop in patient safety events, and it doesn't count for any other of the operational efficiencies, but just on inventory. In NHS, and this number was reported at 18 months into the 2-year Scan for Safety program with audited financial statements and Department of Health teams that went into every one of the 6 trusts to evaluate whether they'd hit all the milestones. They are projecting a £1 billion savings when it actually scales to all 148 trusts in England, approximately a 4-to-1 return on investment, again, only in inventory savings. Nothing has been accounted for by changes in labor costs or changes in safety events. Each of those trusts are reporting a 16 FTE drop in staffing models in their perioperative operating room suites because it takes a nurse far less time to simply barcode scan a patient ID, a surgeon ID, and a product ID, which all upload into the patient's record, which replaces the manual documentation. In the Mercy case, one of the OR nurses said, Anne, I can tell you right now, and she was about 25, I'll never work in another operating room theater that doesn't use point of care scanning. I was shocked. I thought somebody paid her to tell me that. And she said, because it takes me 4 hours in an orthopedic case to document bone graft records from donor to patient. With a point of care scanning, it's about three minutes. So that's what's dropping their clinician staffing time because they're automating the processes that up until then had been manual. In the Mercy system, interestingly, they have reported and documented almost 30% cost per case, surgical case only because they've only implemented it in perioperative in terms of savings of labor cost, which is similar to the NHS, and a 33% decline in supplies cost. So they've dropped their costs on average about 30% for every surgical case. And in the Mercy system, their perioperative program accounts for 60% of their revenues. I'll show you a very brief profile. When they implemented their point of care scanning, the drop in case costing, and this is just an example for total knee arthroscopic, went from 65 to 7,000 US per patient down to just under 5,000 per patient. What they've now done is gone back to the surgeons, orthopedic surgeons, and said, unless you can keep your case costs under $5,000, you won't be given any OR time. And every case, as they leave the operating room, they get their cost per case to know that they've actually hit that threshold. And the other thing they're doing is providing performance indicators for the individual surgeon. So if Dr. Snowdon walks out of this operating room in real time, he or she gets a ranking of what they've just spent on that case. They get it relative to all their other colleagues, and they get it for the timeline, in fact, relative to their colleagues from, in this case, it was August to October. They get scored on whether they're using the prescribed clinical pathways. Their readmission rates are calculated and provided to them in real time, along with the degree to which they're using their operating room blocks and their patient satisfaction levels. So essentially what most of these savings are coming from are just inventory management. I remember collecting all of this data in 3 countries and 3 health systems, and what was surprising and maybe somewhat sad to some degree was nobody's collecting patient safety data that would map on to what degree is quality and safety starting to change, but there's lots of anecdotes suggesting that it does. Mercy is reporting a 70% reduction in something called never events, things that should never happen in a healthcare system. You should never operate on the wrong patient. You should never operate on the wrong body part. You should never leave things in that surgical site. They've dropped those very catastrophic errors by 70% in the system. The NHS tells me the same thing, but I haven't been able to actually acquire the data specifically to show you those numbers. This is a summary of improvements and the level of improvements in costs across 10 US hospitals who to some degree have at least implemented that inventory management system so they can track and trace what products are being purchased for what patient programs and at what savings. What they're finding is an annualized return on investment every year, anywhere from 20% at the lowest in terms of the inventory value health systems are carrying, up to 80 to 90% in terms of things like stockouts. So when you start to digitally track and trace your inventory, where you're using it in what quantities and volumes, suddenly you have transparency so your procurement teams can know exactly what products are needed in what volume so we don't over order and spend a lot of money on products that end up getting discarded because they exceed expiry dates. Generally, in hospitals in North America, what happens is supply chain teams tend to manage consumables, diapers and pads for, patient beds and all those other things. Where the real value is and the early return on investment is in your specialty areas. They spend a great deal of money on products and usually implants. They tend to be managed by clinicians. Clinicians, certainly in our training in nursing, have no line of sight to what a supply chain is, or more importantly, why it matters to us. As soon as you start to work with clinicians and you put clinicians together with supply chain team members and fully integrate supply chain thinking and tools and processes into high cost, high risk clinical settings like interventional radiology, operating rooms, cardiac catheterization labs, you quickly drop your inventory price, but you also create the transparency for every provider team and practitioner to know exactly what we're achieving on quality and safety. So generally, people, when you look at a system-level strategy, and this is just a bit of a graphic to walk through where and how this starts and where it can get to, you start with adopting global standards on your barcoded products. And the reason you do that is because if a hip implant is recalled and it shows evidence of harm in a European health system, you need to be able to identify exactly which implant device is it in North America that we need to pull off our shelves. If we're using proprietary level barcodes, which are often affiliated with our EMR systems, we lose the traceability globally, and that's becoming increasingly important. So as soon as you start to track and trace your products, you get significant savings on inventory optimization. You're not ordering all the things that typically don't get used and get discarded. And you get a lot of automation in the clinical environment for staff, particularly nursing staff, who are simply scanning barcodes rather than documenting manually. That allows you to start tracing products, which products have the best outcomes in which care processes, and you can start very clearly collecting data on costing, accurate costing, and safety surveillance. That allows you here to start to integrate the supply chain thinking and tools into your clinical programs, just like the surgeons who sat down and looked at how much money are each of us spending, and are we getting more value for that spend or the same or less, and making decisions on standardizing care processes that achieve the best outcomes versus standardizing the products we use to similarly have the safest outcomes. That traceability now, which very few are getting to, and Mercy is close or closest, allows you to now start looking at your population segments across the journey of care. So it's one thing to look at how does a particular surgical procedure unfold and does it achieve outcomes for patients, rather than looking at an entire population to look at are the best practice pathways we are using for our patients with multiple chronic illnesses, what's working best for whom and under what circumstances. And that's really the value of the system, but very few have gotten there quite yet. Some are close, but not there yet. What we're also now starting to work on is how do you leverage technologies like artificial intelligence tools to create the predictive analytics based on real-world evidence. So if these 3 healthcare systems, or Denmark does the same, where you're tracking and tracing, you know exactly what works best for which population segment in your health system, now you create predictive algorithms and tools using AI that says, as that patient walks in the clinician's clinic or room and talks about the challenges they're facing, you're using and leveraging real-world evidence to know for your particular hip implant surgery, the best product might be the ceramic with the cement with antibiotics embedded in it, because based on 3 countries' registries of joint replacement surgery outcomes, that's your safest and your lowest risk. We haven't got there yet. The technology is actually off the shelf. And we are working towards creating those analytics tools so that we don't wait for problems to happen. We don't wait for safety events to unfold. We actually proactively identify the risk of the event, allows that clinician to get alerted to prevent that outcome, and then you have much greater health and better outcomes clinically. You also have an opportunity to personalize. And when I say personalization, if you know exactly what works best for women with this diagnosis between the ages of 45 and 55, then you personalize to that population segment rather than just simply personalizing to the genetic makeup of a particular individual. And that's really where we're going to get to sustainable health systems that achieve the best value for each of the population segments based on real-world evidence of what we're able to achieve or not achieve. Where this is next going, and this is a picture of Mercy, is virtual care delivery. You live in a country, as I do, where we have large landmass and we have remote communities that don't have the specialty care that they may need at any given time. Virtual care is now starting with those built-in predictive modeling and algorithms, being able to deliver telehospital care, or hospitalist, tele-ICU, telesepsis, telestroke. Those are all programs that Mercy is delivering virtually. They haven't started tracking and tracing the virtual care delivery system to outcomes, but they certainly are well positioned given their supply chain strategy. So I started talking about supply chain maturity. Then the question becomes, where do we start and how do you embed and scale a supply chain that's high performing and going to achieve all those outcomes that we've talked about, quality and safety? There was no such thing as a supply chain maturity model 2 years ago when I started, so we did a very empirical-based study of all the literature, of everything we currently know about supply chain maturity, the phases, and the strategies. We have now created something called the H-SIMM, which will be launched at HIMSS in the next few weeks. It's modeled after the EMRAM, so that it now mirrors how systems have been able to digitize their system with the electronic patient medical record. It's based on evidence and critical analysis of what we know works and doesn't work, mostly from other sectors. It has 7 levels of progress. Measuring where you are and where you're starting for is mapped out on the key indicators that the literature suggests are important in supply chain maturity. So it allows systems essentially to know where are we starting and where are the guideposts in terms of progressing. Really what an integrated supply chain system does is it takes all your ERP supplier data on costing and products and blends it and integrates it with all of your patient information side. And that's where you get real-world evidence of what care pathways are working best for whom, and at what cost and what value you're spending on products in what volumes for which patient groups to get a truly integrated, mature supply chain infrastructure. So it's about moving from our system to one of delivering population health and experience of care to actually delivering value from a very consumer-focused model. One other very quick thing we're doing is assembling joint registry data across country jurisdictions where country-level outcomes can be educate or learn from each other. So this is a quick illustration of the Canadian joint registry outcomes. Notice that our length of stay is less than the English length of stay, and yet we're spending more money on a shorter hospital stay. And then when we start to compare revisions of those implants, we have almost a much higher rate of revision than our colleagues, less than 1% in England and Wales. So we've already started looking at what can we learn from the English health system to help drop our revision rates as low as theirs are and spend and achieve much better value for our patients. So with that, I will close and thank you ever so much for the opportunity to share this work with you, and very happy if we have time to answer questions.
Okay, thank you very much, Anne. It was very exciting, I think. There must be a question here. Tracking and tracing.
Yes.
Just a minute, we have to use the microphone.
A very interesting talk you had.
Thank you.
You talked a lot about transparency, and it gave economically sense and meaning, and also for the patients, not bad outcome. But what was the staff satisfaction, the doctors, the nurses, the healthcare personals? Did they like the system and the transparency, or did they feel that Big Brother was watching them?
No, it's a good question. The key factor or key condition for success in every one of those systems, with the exception of Alberta, because they haven't got to the clinician level yet, is putting clinicians, and particularly not just clinicians, physicians, in leadership roles to design and lead the implementation and the use of the data. So when you in every case, when they provided those surgeons with their data, no questions asked, no expectations, here's what the system's generating, they immediately took leadership and decided what was best and what would work best for the clinician team and the surgeon specifically. One of the things that completely changed the game on was surgeon preference cards. So if you have 65 orthopedic surgeons in an operating room, they typically have 65 different versions of the surgical tray they use for that case, which is wildly expensive, and a lot of it's wasted. They were able to demonstrate the very objective evidence to every individual surgeon and said, look, there's 30% of the products on your tray you never use. Is it okay if we take them off? When I spoke to the surgeons, they said, look, it's the first time anyone's ever showed me objective evidence of where we could actually save costs, but actually maintain safety. So they were all in as long as you put them in a leadership role to make decisions. If you tell surgeons what to do, and most of it was surgeons because they were all in operating rooms, frankly, you're dead in the water because that doesn't work for them. Show me the evidence and let them make the best clinical decisions. And it tended to work very well. Now, that's in 3 healthcare systems. I don't know if that's all of them, but it was very consistent across the three settings.
So that would be a message to the politicians and the directors. And I have one question, if I may.
So grassroots leadership is absolutely critical, but top-down policies, frameworks, and resources to allow them to make this happen. It's the combination of top-down, bottom-up. It's not one or the other. Canada has a long track record of telling clinicians what to do, and has failed pretty much every time.
Okay, I think that was it. Anybody else?
Thank you very much for an interesting presentation. I'd like to ask you, did you come across some further needs for competencies within the healthcare people or staff or professionals? Since I represent an educational institution, I'm interested in what does this provide for new competence needs in the healthcare professionals?
So really interesting question, and it's very, very early evidence. One of the NHS trusts uploaded their HR data into the point of care scanning so that when a clinician walked into a patient's room, for example, to, I don't know, insert a chest tube, you barcode scan the name tag of the provider, the clinician, and you barcode scan the patient and the process of care you're about to start, a chest tube insertion. The barcode scanner will tell you you do not have the certification to implement that procedure, and that given your level, like perhaps you're a medical student or a resident. So they actually mapped their clinician competencies certifications to who was in the patient's room for some of these transaction or some of these care procedures. So they had a digital record of who's delivering care, are they at what education level, what experience level, and what certification level in some cases, so they could actually get at where and how do we need to either create policies to ensure only the right provider is in that room at the right time, or how do we, because of our outcomes for patients and quality safety, how do we take that data and now zero in on the types of education workshops or tools or strategies we need to deliver to our clinicians to improve those outcomes. So I only saw it in one setting, but it was a very, very interesting dimension of a supply chain that I haven't seen anywhere else.
Yes. Any other questions?
Thank you for a very interesting speak. You talk a lot about standardization. Where did that start? After the process or in the process or before the process?
Standardization was an outcome of that integrated supply chain data that started to flow that would enable these teams to identify what patients are receiving what care processes and getting to which type of outcome and under what conditions and with what products. So standardization was an outcome of clinical teams having a look at this data to identify why so much variability. Why are some patients doing very well, others not? So it's standardization of clinical practice and standardization of products together. But until you have transparency as to which patients are getting what care from whom and with what products, you have no ability to do that. Okay. And pharmacy is one of the best examples. And pharmacy takes to this system, well, they essentially have been doing this for years, but they tend to be doing it in the private sector in Canada, not so much embedded in the hospital sector. So this was a natural fit for mapping which medications are working best for whom and perhaps why. They don't always know the why, but they certainly know the ones that are tending to cause harm more often than others. So that was really one of the values. One very large academic hospital in Ontario has implemented just end-to-end barcoding for medication administration. In less than a year, they dropped their medication errors 90%. And their goal next year is to eliminate medication errors because the system double checks before every medication is given. So it has pretty impressive outcomes around safety. And guess what? They're not collecting that data. So as a researcher, kind of breaks my heart, but I'm hoping they'll get there.
Actually, pharmacy is my specialty. So I have one more question. The standardization, is that also ready to use drugs, for example, dose dispensing and stuff like that?
I'm not sure if I understand. Is it also...
Dose dispensing?
Oh, dose dispensing.
Yeah.
It varies very, very widely. So in the NHS system so far, it's the simple scan of the barcode on the medication, whether it's a unit dose or it's in bulk. It depends on what setting. In operating room, it's bulk. In clinical units, it's unit dose. So it's the unit of dose which becomes interesting, but highly varied depending on the systems the organizations are using. Some are going from manual medication administration right up to barcoded unit dose. Some are using self-dispensing Pyxis Systems is another one. It's really all over the map. I haven't found two organizations the same quite yet, so quite varied.
Okay. Thank you very much.
Thank you very much.
And
My
it
pleasure
was
to
very,
us.
very inspiring, and
Thank you.
your research seems to be very convincing. So it gave us a lot of things to
Well,
think
if
about.
it's not, I'm certainly here to learn why
So-
wouldn't it work? Because I think we really have to get to the patient safety
Okay.
outcomes, and that's really the primary motivation for me. So thank
Thank
you
you.
so much.
Det var OUH Talks for i dag. Vi holder efterårsferie i næste uge, men vender stærkt tilbage i uge 43. Fortsat god dag.